Hi, good evening, everybody, and welcome to our rural onboarding. We're already in our third week, and this week we're going to be focusing on women's health. And usually we have a maternal health webinar. So we've had some amazing webinars on a whole range of dealing, especially with maternal health emergencies. All of those webinars are going to be available in your resource packs. So tomorrow I'll be sending out the resource packs on women's health, and please do go and look for some of those amazing webinars by Dr. Mandondo and by Prof. Hofmeyer. Has also got some very good advice there in terms of looking after our pregnant women. But before this year, let's focus a little bit on the gynae side, and especially around the cervical cancer screening program in our districts. And this is a topic that actually we're very passionate about in the Eastern Cape. So both Dr. Mandonde and Dr. Jaftau are both very passionate in terms of the prevention of cervical cancer in our areas. So I just want to introduce Dr. Mandondo. Thank you very much. She's one of our stalwarts here at Rural Onboarding, and she is one of the DCST's obstetricians and gynecologists here in the Amathole district of the Eastern Cape. And she presents the Eastern Cape in the Ministerial Committee of the NCCEMD. She was the winner of the Sama Border Region Local Hero Award for Maternal Health in 2017 for her extraordinary work in maternal health in a rural district in the Eastern Cape. And I can really say with the DCST's Amathole has shown what a difference a DCST team can make to outcomes, and specifically to maternal outcomes, we have noticed. She's passionate about community obstetrics and developing doctors, as well as cervical cancer prevention, and she's a married mom with 3 children. So thank you very much for joining us this evening. I'm going to stop sharing my screen, and you can start sharing your screen, and I'm going to hand over to you, Dr. Mandondo. That looks great. Yeah, you can just put it on slideshow.
All right. All right. Good afternoon, Royal Onboarders. And thank you very much, Madeline, for the kind introduction. It's always a pleasure to be part of this initiative, and it's been a few years running now. And I've totally enjoyed participating in the ones that I could participate. And congratulations to you and the team for the initiative. So I'm going to be talking about the topic we've said, it's prevention of early detection of cervical cancer in the district setting. I have put more slides. I want to make a disclaimer. What has happened is that the Knowledge Hub has developed a module on maternal and child health, on sexual reproductive health, and it has got a module there on cervical cancer. So I've used some of those slides and added a few of mine. And then if you want more information in terms of training for yourself, you can then actually go register on the Knowledge Hub, but you have to do the introductory module 1, and then you'll choose this module. Otherwise, the scope of the program, we're going to talk to the data. We've got 2 units at Frey and Livingston are the only places that do radiation therapy. So we'll look at some of the data from there, talk about HPV, primary, secondary prevention cancer, and then we'll talk about, again, show you a video. Basically, we really want to summarize the benefits of immunization as a key strategy in the prevention of HPV infection and HPV-associated disease. Evaluate the current status of the HPV vaccines, make sure the guidelines are clear, and then strengthen the issues of abnormal management, and then understand colposcopy and cancer treatment and pre-treatment. So if you were to look at women's cancer in women, according to GlobeCan, you can see that the cervical cancer, the breast cancer, they are the leading cancers. And if you can see here, the cases to the deaths, when you do have cervical cancer, it looks like patients present late and they actually die. But in more poorer provinces like ours, in other provinces, breast cancer will be more than cervical cancer, but in ours, it is cervical. Normally, when you want to compare, you've got the issue of cervical cancer, the age standardized incidence rates per 100,000 women. And you can see, if you're looking at us in South Africa, we are in the red, where we are between the 20 and 15. But there are countries, you can see there in America, the incidence is just always less than 0.8. And in Australia, where they've actually had a successful HPV vaccination campaign. So South Africa as a country has subscribed to the WHO 90-70-90 strategy. And what is this? And why are we doing this in this district setting? So one is to make sure that 90% of the girls are fully immunized with HPV vaccine by the age of 15. And we know that I will talk to what is happening in our country. 90%. You need to help us make sure that parents are aware about this and they sign consent for their girls. And our girls are in grade 4 and 5. And then 70% of women must be screened with a high performance test by the age of 35 and again at the age of 45. So we know in South Africa that 70% people should have a pap smear by 30. So I think we're trying to make sure that 70% of women are screened. Then the last part is that 90% of women who have been now identified, with some kind of disease must be treated. So which means 90% of any woman who's had a pap smear then needs to be treated for pre-cancer treatment. And then 90% of women who have a biopsy and are confirmed to have an invasive cancer are actually managed. So this is what the 90-70-90 strategy is all about. So what we have is we've got a registry, which is a collaboration because, the data about cervical cancer was so scarce. So a registry has been opened in collaboration with the ULSA and UCT. And now I just want to show you. So this registry look at retrospective data 2012 to 2016. You can see cancer of the cervix make up 75% of the cancers. And this is followed by uterus at 11%, and then ovary at 4.2 and vulva. And then you look again in the 2021, it still makes up 78%. So there's no change. Now, we need to be careful of thinking that there's cancer for HIV positive people. Because if you look in this data, you will actually see that 39% of patients, which is 1,307, were actually positive. And then 1,160, which is 35%, were negative. But there were 25% where the cervical cancer, the HIV status was unknown. Now, what is of concern is like the stage of diagnosis. There was a time we looked at Western Cape, you'll find stage 1, which is microinvasive cancers. They were not available. I mean, in these microinvasive cancers, you can actually see that, if they have colposcopy services, some patients were detected maybe like 5 to 10%, But if you look at our cases, the earliest stage, like 25% of our patients on stage 2B, and then stage 3, and then you find stage 3B. This is now like where you have got the uterus, the vagina is involved, and it's actually affecting the kidneys as well. So this is very late, and you can see that makes up 54%. So something is going wrong with our screening, and this is what we can see. Now, considering that a number of patients are on ARVs, we're worried about looking at the age of the patients, right, that have the cervical cancer. And you can see that patients who've been on ART for quite a long time may be involved. And you can see that of these patients, 20 to 29-year-olds, you can see that there were 23 patients that were already involved, which made up 12%. And then you can also see that, to 1.4%, but the 30 to 39-year-olds, you can see make up 12.01% of the patients that have got cervical cancer. And this is extremely worrying because it means that people are on treatment, they are getting ARVs, those who are HIV positive. But if we don't do the screening at the start of treatment and do the 3D screening for cervical cancer, then you will see that this becomes a problem. And then if we look at treatment completion, so I think this talk is trying to help us to actually counsel patients appropriately because of those patients that are in the 20 to 29-year-old, because we have got such myths around the disease, you can see that 10 of them completed treatment, but the 13 actually went to treatment and they started but never completed the treatment. So that is very worrying as well. So you can see that the treatment completion rates, they vary, but also the 30 to 39ers, you can see that of 116 completed treatment, but 79, they start treatment. So the question is, what is the myths? How are we counseling our patients? Are we clear about what the treatment is all about? And is the support in our district setting? Because we need to have a navigator who can follow up the patients and actually assist us with this. So basically now, let's go back to the core content of the topic. So basically what causes cancer is actually the HPV virus. And we've got high-risk type, which is 16 and 18, and we've got 6 and 11. And we know that there's a big burden of disease that is causing warts. And the 16 and 18 is really more oncogenic. And the main risk factors is actually HPV. The HIV increases the acceleration of the disease, but other issues will be the early sexual debut, oral contraceptives at an early age, multiple partners, multiple births, smoking, and also the age of when you first had your baby issues. So what are we using in this country as primary prevention? So basically, we started off by vaccinating public schools. And so now from 2013 to now 2023, it will be 10 years since the 9 to 12-year-olds that were in grade 4 and 5 have been treated. And they were treated with the bivalent Cervarix vaccine. But there's an option of Gardasil, but the advantage with Gardasil, it was actually during the 6 and 11. But new evidence, and the children were getting this in April and they were getting it in September in their schools. But there's now clear evidence that actually they didn't have to get it twice. If they got a single dose of the Cervarix, that it was good enough. And if we're looking at the uptake, I'm going to not spend a lot of time, but you can see that in the initial data, like 5 years into the program, 79% of the patients were actually being treated, and we only had 21% that were not immunized for various reasons, like absent from school, if there were no consents, and then others were underage. So there were various reasons why the 9% wasn't. So what about this HPV? So most infections, they actually, if you have the natural history, the most infections will actually clear within 8 months. And there's a very high percentage of young people initiating sexual activity before. They are not even aware of the consequences of acquiring the HPV as early. But now, anyway, the benefit is that most of them will clear the infection, but some of them will actually get the precursors, or the HPV-related disease. So who gets infected? 80% of people will be infected with HPV in their lifetime. And whether it's through genital, anogenital, oral genital, and manual genital. So because this thing, some of the virgins, the girls will be virgins, but because they do touching of genitals, it can also be an issue. And then what studies was being done, if you can look at the evidence there, that the 50% of students were in high school engaged in sex, and those in grade 9, and 2/3 of grade 12 are engaged in sexual intercourse. Therefore, the HPV-associated disease, as we said, that we had these cutaneous ones, which will be once in the mouth, then others will have low risk, like the 6 and 11, which will really cause laryngeal genital warts and laryngeal papillomas, but most of it will cause the cancers, like mainly cervical, but males can also be affected with anogenital, and then there could be oropharyngeal. I hope it's still there. Okay, so if we're going to look at now, once you do have the HPV disease, then it will then interact with the host immune system. And then there are two cofactors that you need to always verify. Is the issue of smoking and the issue of vitamin A deficiency. So this now will then complete the loop. So when we're looking at HPV, so why are we doing it before the children are 11 to 12-year-olds, the HPV? Because it actually modeling shows greater impact, right, if given before the onset of sexual activity, to give the HPV vaccine. And then also the antibody response in the young children between 11 and 15 years is actually quite great, and then that of the 16 to the 26-year-olds. And now once you've then had the vaccine, then your antibody titers are persistent for more than 6 years. And then the vaccine is also very well tolerated in these groups. And therefore, it's actually a big advantage to take it before they are 11 to 12. And then in Australia, they started much earlier. In 7 years, there was a lot of disease related to genital warts, right? And in Australia, you could find that there was such a significant decrease from 18.4% to, in 2013-14, to 1.1%, reduction in warts. And if you've seen patients with warts, with genital warts, so we're looking forward to sort of establish. I'm not sure if from our data we'll be able to see this benefit with 10 years of treatment. And the issue of missed opportunities, really, I think that the most common thing was this issue of non-vaccination. Our parents was that they were never offered. And also the other thing that was of concern is that people can be in farm schools, they may not be in public schools, and therefore in those schools that are not public schools, people do not get the vaccine. And even though then people would have accepted it, there was no access. So this is what's new, and then this is what is actually going to change. So once you do have then the HPV, we said that you'll have the HPV, between the age of 15 and 30, and then it will persist, and then the levels will come down, and then if your immune system is good, it will come down. And then that is why most people, then the cervical cancer screening was almost at the age of 30 years. That is when the precancer lesions will then start rising, after you've had HPV for a while. And then that is then when most patients will then start developing cancer, as you can see, as we can see here. Okay, I wanted to try and look for a pointer. All right, then, okay, so only a few cases will become cancer, but you can see that HPV disease is actually common. Oh, what do I do now? Okay,
Just
I'm sorry.
click on the screen and it will go forward. If you click on the screen, it will go forward.
Okay. Oh, thank you. So in terms of the same thing, in terms of pictures, you can see a normal cervix. Once it's HPV infected, the very same cervix will then actually start being affected. And you can see the next picture is when you can see the persistent HPV infection, which is the raised acetal white lesion. And then it becomes a cervical cancer. And this may take 10 to 15 years to actually develop. So what are we then going to do for the people who are not vaccinated, which is the greater population of our adults? We're going to be looking at pap smears. There were pap smears initially, then we moved to what we call liquid-based cytology. And then there was also other places are doing visual inspection with acetic acid. And now I'm going to say something about HPV DNA testing, because there will be some pilot districts that will move away from. It's exactly the same procedure. I'm talking about the HPV DNA testing, so I will explain how it's done. So we're all using a brush to actually take and put it in a liquid medium. And when we put it into the liquid medium, we're able to ascertain, we call it liquid-based cytology, but on the very same specimen, you're gonna sample the same way, and then you can take it, and then you can say, okay, I'm looking for the cytology, but I'm also looking for an HPV DNA test on the same specimen, same technique. So there won't be any change in terms of like the retraining of staff to be able to do that. These pictures are actually very useful. I think putting this on the patient, when you explain to a patient that, look, when you've got ascars and low cell, you've got the pink cells in one layer, you can make it simple. And then when you've got CIN2 and 3, the problem is with our cytology findings is that they always say something is high cell, and you never know which one of the two high cells. You can see that with CIN2, you've got the two rows that are actually affected, but with the other CIN3, you actually have got no normal tissue at all, and therefore all you have is a basement membrane, of which now it's easy now for it to convert to a cervical cancer. So that is why it's important that you actually, when you have high cell results, those high cell results must be prioritized, and those patients must be linked to care. Okay, I need to just explain about the pap smear results. So the first one, sometimes you get absent endocervical cells, and then they say you must repeat. This is dangerous because it just talks to your technique. If there is a video that will put on the resource page that will show you that when you do a sampling, you need to go make sure that the endocervical cells are covered, and then you need to rotate the brush almost 1.5 times. And when you've done the rotation 1.5 times, then you need to put the brush into the liquid-based medium. And then you will then make sure that when you've done that, you've obtained the endocervical component. So when they say it's absent, then it means that, there's an absence of at least 10 well-preserved endocervical cells or squamous metaplastic cells. This is actually quite common in adolescents as well as in the postmenopausal, because, the cervix can be atrophic, and so the incidence would be 10 to 20%. Now, the clinical significance is that the problem is that when you are screening for cancer, you want ectocervical, and it could be the endocervix that is also involved. So if then it's absent, why are we repeating? It's because there's a much higher risk of dysplasia that now, if you don't know you have enough of the cells to sample, so it's very important that one will work on if there is no endocervical cells and the patient doesn't belong to either two groups. So if the patient is postmenopausal, the report will say absent endocervical cells, but then it will comment and say, but this is of no significance, and they won't make you repeat. But then in other age groups, they may make you repeat. So the next thing I want us to talk about is the low cell. Normally, it's about HPV with a C1, And the important thing is that when you have low cells, they are repeated, there's a higher regression rate. So we don't want to jump in. When you've got a low cell, you don't want to jump in. But the problem in our setting that I want to highlight is that a lot of patients will actually have abnormal cell lesions, will have cancer, and somebody done a pap smear on a patient with cancer, which is not supposed to be done. They were supposed to refer the patient for biopsy. So what I'm suggesting, even if the patient comes to you into your clinic, gyno-PD, and they've got a low cell PEP, rather examine the cervix, examine the patient, put a spatula, make sure that it all looks normal. And it's only after you've looked at it that you, and then if it's at a colposcopy clinic and you don't do colpos, but you just do acetic acid, then put acetic acid and glucose, and then you'll be able to verify. Then when we've got the high cell lesions, this could be 2 or 3, there's a high progression rate. It really doesn't really regress much, and therefore it can also affect. So all of the patients with high cells then tend to be to blind. Now, we saw like yesterday, somebody sent me a message saying, look, here's a patient with ASCAS, and somebody is suggesting we must put Premarin cream. So atypical squamous cells basically have, so they have ASCAS really, they're more difficult to predict and the low cells. So really we tend to repeat, and after maybe 2 repeats, then we can refer. Okay, so it's not supposed to be 2 repeats, right? And then what is now going to be effective now is because instead of keeping on repeating the ASCAS and repeating the ASCAS, and it persists, it's more important if you did a core testing with HPV DNA, then and you've got an oncogenic type, then the patient needs poscopy. So this is a test that's going to be available to us, and now there's also the issue of ask age. So atypical squamous cells, but high cell is not excluded. So the problem here is that you are seeing a very normal pap smear, but it's got 5 to 10% of the cells that look atypical. So this can be a mixture of through high cell, and the other findings can mimic other lesions. Therefore, there is a higher potential to progress and persist. So if you have this, these patients must always do colposcopy, but also in terms of the technique of doing a study of sampling, you can avoid having ask-H's by making sure you've done 1.5 times around the cervix with your brush to actually eliminate this. Okay, now atypical glandulars should not be going to colposcopy. Atypical glandular cells is actually is worrying because the patient 10 to 39% have got a true squamous or glandular abnormality. So now the question is, you don't know if this glandular abnormality is, you remember columnar cells will be in the endocervical canal and also in the endometrium. So what then needs to happen is that they will say it's endocervical, there could be endometrial, then there will be not otherwise specified, or they will talk to atypical glandular cells that favor neoplastic. So this is worrying, right? So, and then the others will say this is an adenocarcinoma in situ. So I think the take-home message is that whenever you see a patient with atypical glandular cells, these patients, there is some guidelines say refer to colposcopy, but it's not what you should be doing. The patients must go to the gyno-OPD, and then in the gyno-OPD, the investigation of choice is actually doing a hysteroscopy. Then with hysteroscopy, then you'll be able to view the endometrium and the cervix, and then you do then you can use an endometrial cellular, or you can do a biopsy, which is guided by the hysteroscopy. So as we can see, it's really showing us the patterns that low cells 60% will regress, HPV will progress 20%. Then you can see the high cell CIN 2 to 3, 40% can actually become invasive. So if we look at our different districts, the more low cells than the high cells. So you can see this is the different districts in the Eastern Cape, and we looked at 10 years of what the results show. So and that 7% or more of the patients will actually have a high cell, and then the low cell, the low cell, and then the high cells will actually be around 2% of the total pack of the patients. But what is actually quite concerning is now, why are we going to have high cell and then we see cancer, right, malignancy in a cytology report? So this is very worrying, and you can see in Amathole there was a time where there was a high numbers of that in Joe. And we should be seeing less or very little now, and no cancer on cytology if we were sampling correctly or referring patients with lesions, abnormal lesions appropriately. So I think this is something we need to watch out for and educate our nurses around. So what is the screening algorithm currently? So this is the algorithm. We'd like to develop it to look nicer, but basically, if you have a pap smear, if it's negative, if you are in a low risk group, immunocompetent women, right? Therefore, with those women, if the pap smear is negative, they're screened in 10 years. Nothing has changed about that. But then if you've got the patients that have got Ask Us, we've talked about Ask Us and low cell, they are risk screened in 1 year. Remember, in the past, we were risk screening them in 1 year. And then Ask Age, high cell, or patients with cancer, they get either biopsy or they go to colposcopy. And then after they've been to colposcopy and they've had biopsy, then you can either confirm that it's negative when they have a scene one, right? After they've had a colposcope, then they can be rescreened in 3 years. And then when they've got scene 2 or 3, we've got different modalities to treat. So this could be cryotherapy, or because now cryotherapy uses a lot of equipment, we actually go to the legs or the lip, which we'll talk about, and then these patients then will be rescreened with a pap smear after 6 months after they've had a treatment. What are the key differences with the HIV positive patients? It's basically that even if they've got a pap smear, they are screened every 3 years, and then everything else is the same. So if you then have negative scene 1, you rescreen in a year, right? So if this is negative, then once they've had a positive or an abnormal pap, then they go back to the rescreening yearly. Versus the people who are HIV negative, then we're going to have a rescreening 3 yearly if they ever had an abnormality. So these ones would have a yearly rescreening, and then they will also have a less procedure. Next generation. So I was talking to the HPV DNA testing and the benefit of actually moving to primarily just screening everyone for HPV DNA is because it's more sensitive and specific. The slide is busy, so I'm not going to read everything. And it's also going to help us with the low cells and the ASCAS because you're now going to follow up more aggressively the ones who have got ASCAS or low cell but who have got HPV DNA positive. The benefit of doing that is that the technique to do it, there is going to be, you can do it exactly the same way as LPC, but then there's an issue of where you can take a self-sampling using a tampon, and the patient then can sample with a tampon or something that looks like an earbud, and it can be put in a sample. So those people who like sex workers, those people who are reluctant to go to the clinic because the people say we have attitudes, they say they are told they're dirty, they can't have pap smears after 12 or after a certain time. So I think this is actually going to assist us with that. I'm going to skip this, but it's basically saying there's a proposal to say, look, patients who are 25 years and older must just have this HPV DNA testing. And therefore, but now what will happen if now you're HPV DNA positive? So if you are positive, then the lab will automatically then take the HPV DNA positive patient and do a liquid-based cytology like a pap smear on the same test. This is on the right hand side of the screen. And once they've then done the test, then you will then see what the pap smear will show. It will give you a high cell, ASCAS, the same thing. And then you will then do when you now have an HPV positive, and then you've got a cytology, then the patient will go now to the colposcopy clinic because we know that there's poor skill in terms of there's not enough colposcopes everywhere and people don't have the skills to do it. So because of this now, it's going to be the triaging test will actually be the reflex cytology, And if patients are negative, then they will have another follow-up HPV after 12 months. In the district, you're supposed to have what is called a district colposcopy cervical unit. And the most critical patient, this is just the equipment that's there. But the most important person is what we call minimum equipment and service package, a navigator. Somebody needs to pay attention to the results, get the results, record the results, and make sure the patients get to be aware of the results. And it's amazing when we look at NHLS, we get a lot of patients with abnormal results that have never come back to the clinic to actually go and see that and access those results. And then in terms of clinicians, all district doctors are supposed to be able to really assess a patient, at least visual inspection, acetic acid, and be able to conduct a LETS or to do a biopsy. Those people are not from the Eastern Cape. The Eastern Cape units have been provided with a LETS booking, which looks like this. And then in this booking, there's actually patients' names, where she came from, who was referring. And then there's the pap smear, and there's also a block about the HPV DNA result, if there was a comment and when the date it was done. Then when she comes for treatment, then you're going to be able to say, this is the treatment you did. But the amazing part about this register, this is a register we developed with the department. I was part of the team that developed and copying other systems. But the advantage of this system is that when you biopsy, then it says what was the biopsy result. Was it communicated to the patient? If the patient is not aware of the result, so whenever you get results, you must open them, it must print it, and you must put what the results are. But also, what is also nice about it is that after the patient has had a LETS, they come back for the LETS, and after the LETS, they have another pap smear. You enter the results of that pap smear. What was it? And then the post-LETS, and then you remember that when you've had one LETS, you can actually have a post-LETS procedure. And then you can make any remarks. So I think that this is an important, my second point is we've talked about HPV. You help us make sure that the patients are counseled and have access. Secondary prevention, do the pap smears, make sure that all patients who are HIV positive, they get the test. Then once the results, we have to do the managing of the results, like I've explained. Then at least must have a record. So if people want to get a copy of what this register looks like, we can print it in A4, just put high cover, people can get it. And then the next thing is that the visual inspection acetic acid, just who don't have doctors, they can still do this visual inspection. We are doing it like that. We are doing visual inspection, and then we are doing LETS procedures. So what are you supposed to look at? So at least this, you must know what are you looking for, like the transformation, where is it? So you must see that, okay, then you'll have an internal os, then you'll have the original squamous columnar junction and the new junction. And the transformation zone is the zone that is actually in between. That is actually in between. And that is the part that is most likely to have some kind of transformation and actually change and have the precancer cells. So this is what you are going to look at in your cervix, in a normal looking cervix. Then colposcopes, we've got two types. Other people have got new small ones, but usually these are the ones that are still available these days. Colposcope, but there's digital ones that can be linked to a phone. I don't know what you're using in your province. Then it's important that on this we must have the punch biopsy forceps so that we actually do the punch biopsy when it's needed. Then in terms of machines, others have got this Furnace Leads machine in Eastern Cape, but a machine that is specifically. So now if you are using this machine, this is the normal diathermy machine. So there's no problem. You can use the normal diathermy machine, you set it at 50, and then you buy the loops and these roller balls. And the loops come in different sizes, so you must choose the different sizes. And younger patients with a big cervix will need a bigger loop. So this is the basic equipment, but I think we had a donation of a different type of machine, which doesn't need a diathermy pad. You just slide on the way you're on the machine, and then there's no diathermy pad, and then it comes automatically with a smoke extractor. But in this setting, you wouldn't have a smoke extractor. And then what about colposcopy? So I don't think district hospitals are expected to do colposcopy. I think it's visual inspection, acetic acid, and where you can then do a LETS, you're doing it both as a screening and as a treatment. So, but where there is a LETS machine, you would put acetic acid, and then this will be a dense acetal white. This is when you call it mosaicism. Then it will appear like this, and then you can have these cross punctations that you can see. So this will be for another day. And these are the different pictures. So as long as it doesn't look white and red, it's got other features on it, then you need to then look at that. So the most important thing when you are learning to do LETS is it's very important that you put the locals, because now once you then, even if you cannot do it, you haven't done you haven't done a colposcope, then the locals will then have decreased uptake where there's dysplasia, like you can see in the last picture, which is the G. And then in that G, then you're going to make sure that you excise this lesion. and you are beyond the margins of this lesion, and then you're going to cauterize right around the edge of that margin. So even the least experienced of persons, if they can put locals, then they will be able to identify where the lesion is, because the actual lesion will not take up the locals. I think this is repeat. So you can actually see this lesion. This is what it looked like. It was not so clear when it was aceto-white, but when you put the locals. So if you did a colposcope, then there's 4 things you look at. It's an aceto-white uptake, then you've got margins, you've got vessels, and then you've got the lesion size. So basically, eyeballing, you say, does it affect 2 quadrants? Does it affect 3 or 4 quadrants on the lesion that you can see? So for everything that you do, basically you score it, a 0, or 1, or a 2. So when it's dense aceto-white, it's a 2. When there's sharp, then with cuffing, then it's the margins are raised. Then when there's atypical vessels, then it's a 2. Therefore, if you have like something between 1 and 2, then basically it's equivalent to a CIN1. And when you've got 5 and more, then it means it's a CIN3. So by just basically doing this, you can circle. So the advantage is that people can be given the stationary, and if you have the stationary, then you just circle, and then you add up your figures. So you don't have to think, you don't have to memorize this in these forms, and then you can just circle. And remember that after you've done a list, there's no reason when a patient is coming for their results, you don't have to look at the cervix per se. You don't have to get the cervix per se. So what you then, this is what it will look like, after the lets, initially, but after a while, after they've had lets, then you will see that it will look a bit stenotic. So what I want to emphasize with this is that when it does, sometimes in follow-up, you find the cervix a little bit, like I had a patient today, and I didn't understand. I was doing a cold clinic, and I tried to sample, but she didn't give a full history. So I looked at the cervix and thought, this cervix looks so atrophic, it looks so small, it looks so short. This looks like someone who's actually had a LETS procedure or a number of LETS procedures. And then, but it was not written in the referral letter. And then when I tried to explain the LETS procedure is, then she volunteered that, yeah, no, I'm not from Eastern Cape, I'm from Cape Town. And I've had 2 LETS procedures in Cape Town. So this was a follow-up pap smear that I was actually doing, and yet the person didn't take a clear history. But I think if you learn to look, then you sometimes recognize, but sometimes really a lot of services post-lets look very, very normal, especially in younger patients. So it's not something you want. What do you tell patients? So sometimes patients come to us towards the end of the year, and like December, patients are coming referred to the clinic, but their husbands are back on holiday, and all that. So before you do the procedure, you must explain the side effects, and you must explain that what is going to happen, because some patients will then say, okay, you may have a bit of cramps, that's rare. You're going to bleed, you're going to spot, for the next 3 weeks after you've had this or discharge. There could be heavy vaginal bleeding, but you may have some pain, and then you can have some discharge. So some patients, when they know, and then you must tell them that they're going to abstain from sex for a whole month. So if that is the case, somebody has got a partner visiting, they were going on holiday, they may not be as keen to continue with the treatment that you are actually offering. Now, in terms of the LETS report, it's actually very important that you study in detail the LETS report. So you can see that, so the most controversial thing that I see, look at the lesions. You can see it was 15 by 14 by 4, and there was another smaller lesion, but also then look at the LETS, like look at what are they saying. So you can see that the lesion, it was a grade 3. So where you had a colpo and you had an impression that it was a SIM3, then you can say that now when you get the report, the advantage is that you can get a cytology result. And when you do get the result, the report from the LETS, it confirms that this patient was indeed on histology now also a SIM3. This is what you look. Make sure it says that there was no invasive malignancy. Then you also see that the SIM3 is present in the cervical margins, and then the extracervical margins were not involved by the dysplasia. Chronic cervicitis, there is no associated glandular dysplasia. So when you see this, you can actually, the margins, remember the margins they're referring to is of the excised piece that you took, but whenever you're doing a LETS, you must routinely actually look at you must really burn right, all the margins. When you do that, then a lot of the tissue, those cells have been destroyed by the coagulation, and therefore, if you do that, then when it says that the margins are involved, it doesn't mean the person needs a relapse. All patients who've had a relapse, they need, if it says no cancer, even if it says the margins were still involved, all you want to do is to have a repeat pap smear after that. Okay, can I get a feel of how many people maybe raise a hand or whatever you can do, like who's doing lets in the room? People can say yes, unmute, or are they muted, Madeline?
Well, they can actually put it in the chat, maybe. Put a yes or no in the chat.
Yes.
Or you can
And,
put it,
and
the reaction should work. We had some chat problems, but the chat's working now with some no's there. I think the question is anybody actually doing letters? Is there anybody out there that's actually doing it in a district setting?
yes, I think everyone who is doing it, they can write the name of the hospital and they say, we are doing letters. And if somebody says that I know how to do a colposcope, we have a colposcope and we actually use it. If you are one of those people that is doing that, it would be helpful to put it in the chat as well.
So it looks like Dr. Forba from Barberton Hospital, they've got a let there. And Mussolini, Lungile, yes, is also there. Graham is hoping to start at Isimelele soon. And Mbongalwana saying yes as well.
All right, so excellent. So we can actually help. Yeah, you can try and get the registers and the things that we are talking about. So I'm going to tell you about something that there was a pilot study here at Fred called SESTA. And also in Western Cape, because remember, the consumables to actually do a LES procedure, you need a suction, you need a diathermy, you need consumables, lead sleep, there's a risk of organ injury and all that, But in Western Cape, then they decided to start in Khayelitsha and many other centers are using what is called thermal ablation. So with thermal ablation, it's literally the equipment that's really on the pockets here. So it's a pocket-sized device that is actually sitting like in the picture. So basically, you do everything. So this lesion is treated with the Teflon-coated probe, right? It bends. So it bends like you can press and then it will reach up to 100 to 200. So then this probe is then applied to the cervix for 30 to 40 seconds, ensuring that the whole transformation zone, right, is actually cut and destroyed beyond the limit of white lesion. So if the lesion is very big, maybe this doesn't work, but most of the time the lesions are much smaller. So then you put a cream after a week after it has been done, and then you avoid intercourse and you don't put tampons. So you can imagine if you just, it's now literally the same as what you do if you're going to do a pap smear. You're actually going to just put a sputum and then you're going to put acetate white, and then you can then just bend, using this device. And it works like a bomb, and there's no bleeding, there's less consumables, and this is doable, and you can do it. You can go to outreach, you can visit other places and actually use this. So Frey has had this, and they were donated, but I think we are hoping that sooner or later we're going to move with this thermal ablation. I think the skill will be much easier and the risk will be much easier for doctors to use. So what are the advantages is that all the grades of the lesion can be treated in the outpatients. It's painless, safe and efficient, short duration, short treatment time, and well accepted by patients. The only disadvantage is that with the current leads, you actually send a specimen to histology and you get results. So with this one, there's no histological confirmation. And the success rate for treatment, remember, you're going to do another pap smear after you've done this, is very good. 95% for SIN 3, SIN 1 and 2, 96.5. And people will need one treatment, but you can need more treatment. And the persistent disease is actually low at 7%, and the recurrence rate is actually low at almost 5.6%. Okay, so this is the machine. It comes in a little small bag, it's like an ENT set, basically, I think bigger than an ENT set. And then those are the pieces. What are people talking about when they talk about cryotherapy? Really, it's ice. So basically, when you have thermal ablation, you are heating the cervix, and it actually destroys the precancer cells. But then when you do cryotherapy, you're actually freezing. So which is basically you're going to use the cytoprobe. We're no longer doing this in our setting, right? And the complication rate is actually quite lower. And then the LEDs, it's very important that you remind, like when you have a LEDs procedure, the depth is 7 to 10 millimeters. So it's almost a centimeter deep. That's what you're taking. And then now, remember that if you're struggling, you can't localize the cervix. The lesion is too big. You can't see parts of the lesion. You know, it's no longer that no colposcope available. It's not like, you know, the colposcope is not really a prerequisite now for treatment. But sometimes you see that there's a lot of discrepancy between what you see, or there's a suspect of microinvasion. So what will happen is that people can actually do a cone biopsy and it will be a treatment as well. So, but this will be done in theatre, and it's only now tertiary and regional hospitals that do the cones, and it's actually important that we make this as a treatment. What I want to say is that, okay, so I think one slide disappeared. There is a lot of pressure from patients. The minute they've got thin lesions, they want a hysterectomy. And I think that what was on the slide that I'm missing is that if the patient has a hysterectomy, they must understand that it's not a solution, because if you have a LEDs, you're gonna just have a follow-up and pap smears yearly, you know, for up to 5 years, if everything. But now if a person says, no, the cervix is abnormal, I want to have, I definitely am sure I want this removed. What is the disadvantage of that is that they still need to go and have a vault smears. So because remember your HPV disease is in the vagina, so the patient will continue to have vault pap smears, you know, and have the same follow-up that they were going to have if they had a lab procedure, which is LEDs. So I think it's very important that patient must be clear about that, and therefore, but if now, like they have recurrent, if after LEDs, 2 LEDs procedures, then they continue to still have nice CI entry, then the hysterectomy is actually indicated. Okay, so I think that at this point, I'm just going to talk about the cervical cancer. What if you look there and you actually see a lesion which is suspected to actually be a cancerous lesion? So you're going to biopsy it. So remember that our goal is the 70 HPV testing. Then we said 90%, 90 is HPV, 70. We want to make sure that the women are screened. But then we want to make sure now our survey says if you have a precancer lesion, you need to track and make sure 70% of all your treatments are treated. But now, what if look the result comes back, say you have a cancer, or the patient looked like they came with a pap smear, but when she comes and you examine, you actually see a cancer. What must we do? We must make sure that 90% of those patients go to treatment at a tertiary. You know, this is tertiary prevention now. So how are we going to do this? So what are the treatment modalities? That depends on the phase, on the stage. A lot of patients, when they are told they've got cancer, they want a hysterectomy. But the reality is that, as we could see earlier, on the stage of the cancer means most patients present at a late stage for hysterectomy. So I think one of the reasons that we look at in terms of why the cervical cancer will not really eliminating is because the signs are so common. In all our OPDs, early signs, vaginal discharge, fast swelling, irregular bleeding, postcoital bleeding, postmenopausal bleeding, or spotting. These must be taken seriously, and we must make sure that we assess the patients and investigate them if there are these signs. But now you've got other late signs, which is frequency or urgency in urination. So when now the lesion is starting to be bigger, 4 centimeters or whatever, then it compresses in the bladder. And when it does, the patient will have an urgency in urination. Sometimes it will cause a back pain and low abdominal pain. So this is also frequency terms, you know, so it's important that you think back to very late signs. So whenever you see patients, there's weight loss now, I think this is very important when you counsel a patient where you suspect there's cancer, to explain the progression of the disease to the patient and say, look, now you have an early cancer, but if you do not take your chemoradiation and you're going to go to radiotherapy, you're eventually going to leak, you know, you're going to have reduced urine output because of the renal failure. Eventually, you're going to have a leakage. You know, the cancer is compressing on your bladder. It is attached to your rectum. You're going to have a leakage of urine or feces through the vagina. Then eventually, when the disease becomes much more severe, then it's going to obstruct venous returns. So the patients could have swollen legs, they can have a DVT on one leg. And then also then if it becomes stage 4, it will go to the other sides, like to their lungs or to the brain. And therefore, if the patients must understand that once we've arrived at the diagnosis that they have cancer, then at least normally within 6 weeks or 2 months, they can go to chemoradiation. But I find that initially you try and explain to patients, and patients say, no, I'm going to go to a traditional healer, I'm going to try this. And then by the time they come back, they're leaking urine. And then they spread this bladder involvement, and then they blame it on the chemoradiation instead of on the delay. That's why they will not start treatment without a CT or a kidneys, ureters, bladders to actually look for potential invasion. So this is just showing you that with all those stages, the treatment success. So you can see normally with cancer, look at 5-year survival. So if you have carcinoma in situ, which normally we pick it up at colposcope, 100% survival. Early stage cancer, 85% survival. But once we start taking stage 2 disease, which we said is 25%, but you can see that it's 65%. So the disease is beyond the cervix, but not to the pelvic wall or to the lower third of the vagina. That is stage 2, but only 25% of our patients are there. Most of them will be in stage 3, where the disease involves the pelvic side wall and the lower third of the vagina, of which now, then what is the stage of the presentation? So basically 5-year survival in the stage 3 patients. So who can write on the chat, what is the cost of chemoradiation? What do they think it costs the state to treat one patient with cervical cancer and chemoradiation? Can someone write on the chat what they think?
So anybody
if anyone thinks no wants to guess?
I've got 8,000 Rand, 8,000 Rand. Any other offers for how much chemotherapy? Is that per treatment?
Yes.
Chemo at 75,000. We've got 10,000. Ooh, 300,000.
Okay, excellent. It is 100,000, colleagues. So to treat one patient with cervical cancer is 100,000. Now, if you treat this patient with 100,000, but what is the survival rate is 35%. So for every 100,000 we've treated the patient, only 3 of the patients for every 10, right? So that is worrying because we still want to treat the patients. We still say 90% of patients must go to treatment, but with 8-stage disease, the survival gets less. So that's why if we can strengthen the district cervical cancer units, which are very basic, really, then you can find that we're going to start finding more patients in early stage, not in 1, but then the stage 3 disease. The second thing is that if we examine them, people will come to your clinics and say, I've got postcoital bleeding, or I've got dysfunctional bleeding, a young patient. But the tendency is we are so used to this syndromic treatment of STIs, and we don't examine cervixes, and we don't examine the cervixes, and we don't do pap smears in hospital. You write a letter to say the clinic referred the patient for abnormal bleeding to you. You write a letter back and you say, no, the clinic must then be the ones that do the pap smear. That is completely wrong, because what you want to make sure that somebody has done that pap smear and you've looked at that cervix. So please, let's show some services, some love, look at them, and redo the pap smear. It's part of your investigation. It's not good enough to do syndromic treatment. So this is actually very worrying now that we're costing. And I mean, if we can do less procedure, a less procedure is like maybe 700 grand, including the histology, the consumables, everything. So in state, I mean, in private, you're going to pay more because of theater time and other things. But so you've got a treatment which you can pay 1,000 rand less for, which is less. And then you've got a treatment you're going to pay 100,000. And that is the danger. If you do a test, you don't follow up on the results, it's 1,000 rand versus 100,000. And in this situation that we had in terms of financials, it's really a problem. And then basically, you're not expected to all the staging, at least at district hospital. You just need to do the chest X-ray and then the treatment. I said, I think don't give people any expectation. If you have cancer, the likelihood is actually that are going to go for chemoradiation. Surgical is very few patients that are eligible to have just removal of the cervix or removal of a total hysterectomy, total abdominal or radical. But otherwise, most patients have radiation with chemo, and I don't know who knows how radiation works. Who has had a patient that went to radiation? So those patients, they normally are admitted for 4 weeks. They get radiation, they sit under the machine, which is for a few minutes, you know. And I think that it's less than 30 minutes to bring in a patient, them on the bed, treat them with radiation and out, then the next patient can go. You can have to position and all that. But I think that it's important that patients will that the chemo radiation can be done. It will be a month normally, and then after that, they can then have some ablation. So it's actually a month of treatment, and people are able to do it as outpatients, just coming out. They won't vomit, they won't lose hair, and all the side effects. Normally, it's very local, the treatment effects, you know, of the treatment for cervical cancer. So this is, for example, the machine. So this is the lesions that I say, look, watch out for these lesions. Don't say this is infection. Examine this patient, do a PV, do a rectal exam. And then once you start doing a rectal exam, you'll actually appreciate that this lesion is a whole lot bigger than what you be seeing, you know, at first glance. And those people who have never seen a chemo radiation machine, it's something like this, and this is how the chemo radiation is done. So
Yeah, we can't hear the sound on that.
okay, so I think we won't see, but will we hear the sound on yours, Madeline? Okay, I'm gonna skip this video. So, but I just wanted to show people we've got these bags that we donated here in the Eastern Cape. And here on this machine, it's portable, it's chargeable, and you can just do the whole legs, the lip. You don't have any equipment, no diathermy. It's got a suction, everything is in this small bag. So I think that these were donated in the Eastern Cape. I'm not sure if other districts have got this, or they are still using a diathermy machine and a suction, because you need both a diathermy machine and a suction machine, which you have in your theaters. So I think on that, I'm going to ask Madeline to just show us an advocacy video, and then we will take questions. And then also what we've generated is posters. And on these posters, we've distributed these posters in most districts, and you should have these posters. So I'm really going to say thank you all very much for listening. And I hope that this will help you to develop an interest in terms of cervical cancer management, because this is something that we can do something about. And this is something that saves lives. It's not just about a procedure. So on that note, I would prefer that. I'm not sure. I think we still have time to show
Yes,
the
we do
video.
have a few minutes. Doc, would you just stop your share that I can share the video? And then
Okay.
just while I'm getting that up, yeah, there's the HPV self-testing. There's all these amazing things that we hear about, and it feels like it's very far away. But keep a lookout. I think they're going to be introducing these things. Yeah, so there's already very rural facilities that are starting to have access to some of these procedures. The one thing we're very excited about is the self-testing in private already. So Lancet Laboratories in private has got HPV self-testing kits. So for those of you that are in private or have access, if you've got patients who really find it very difficult, the idea of having a smear done, that's something that they can actually get themselves and pick up themselves. And as you've heard, it's got very good sensitivity and specificity. And I think that's where we need to go, is how to make screening easier for our patients. And both the HPV technology as well as the thermal ablation technology is going to make a big difference. I'm just going to play this video and just let me hear.
Okay. All right. Just pause, please. Okay. So
Yeah.
in terms of the acknowledgements, I'm part of the Gynae Cancer Research Center. This center is available in Umtata and also here at Frame. As part of it, we're doing advocacy. So what we are worried that sometimes, okay, somebody's asking about the age group. If the patient, their pap smear was completely normal at the age of 65, you can stop the screening. But there is no age group. You have, if they are coming for the first time, if they've never had a pap smear, then you'll do the first one, even if they're 75. Then when that is normal, then you don't have to rescreen. So, and you will see in this video, like this is, I would like us to actually watch. So with Rotoscare, a lot of people don't know what chemo radiation is all about. They don't know the side effects. Now we have a patient who was like saying, look, I want my people to know what it looks like. You know, I want people to know and get an experience of this. So let us just hear, and it's something you can send by WhatsApp, because sometimes when you're saying you're referring a patient for chemo radiation, then they don't know what it is, but you can WhatsApp the video to them so that they can see someone who's had an experience, and their family can actually watch this patient, watch the feedback from this patient, and then yeah. So I think that it's very important that we can do this. So I think at this point, let us just let's watch this, and it's a video clip and a link that we can share with the resource pack that you can keep on your phone whenever you have a patient that is affected or a family that needs counseling. You can use it. You can play the video, Maternal.
Thank you very much. I've also launched a poll just for HPCSA. Has become fussy that we do actually have to show people who are actually on the call. So please just fill in the 2 questions on the poll for our records, and I'll play the video so long.
Are women okay? Sorry.
Can you hear?
Yes.
Okay, good.
All right.
Yes, so we will definitely add this video to the resource packs as well, because this is a great video to show patients and to have available in your waiting rooms and to forward in WhatsApp on groups, etc. So thank you very much, Dr. Mandondo.
Yeah. All right, thank you. I'll take questions. So I think maybe we're not really able to hear, but what I'm saying is that the presentations sometimes for the late cancer is very atypical. Don't judge and say, oh, this patient is already 60 or she's already 70. If they are keen and you think that they will be compliant, we can explain the treatment. They do get treated, even though the 5-year survival is poor. So I'm not sure if we must put our names on so that we can actually for the CPD points, but I don't know, it's just a poll. But I just want to.
The poll is fine. If you're struggling with the poll, they can put their names in the chat as well. We can pick it up on either way.
All right. So I don't know. I would like to get at least a question or a comment if there's any. I'm not sure what time allows. Thanks for the hands.
I'm just seeing if there's other questions. You've answered the question. Somebody was asking also about the poor mortality and the treatment. But I just want to add with that as well, as I think it's very important, like Dr. Mandondo was also saying, is to really give patients good information when they make decisions about treatment, what exactly they can expect, what the implement, and you want to have that conversation about what people are willing to suffer for a bit of extra time. And I think we're sometimes not so good at having frank conversations about what is possible. We sometimes feel we should just offer as if we have treatment. But if you have a frank discussion with a patient will be able to make a decision. Now, actually, I want to try for that 5%, and I'm willing to go through the 6 weeks daily visits, et cetera, et cetera. Or you might have somebody that says, listen, no, it's quality of life is more important to me. I rather want to get my affairs in order. And being able to have those conversations with patients is very important. On the webinar list and on the Rudasa resources, there's a particular presentation I've done on end-of-life decisions in palliative care and how to have conversations like that. I see there's a question from Angela about the HPV self-kit available in government. Struggling to get women to come back for pap smears. Dr. Mandondo, I don't know if you know how far we are in actually getting access to that.
No, at the moment we don't have. So what we will offer HPV testing, but I think there may be some Buffalo City and some they will select. There's going to be a meeting that will decide who is going to actually have the HPV testing. But at the moment, no, it's only available through like developmental partners. We don't have a partner here in Eastern Cape that is actually giving it to patients. But I think that sooner or later, the self-sampling will help us. That is why the government is looking at self-sampling to say, look, the patients can be just all sitting in the queue, and then they can do the self-sampling, and then just give this. They can do it at home. We can engage people in the villages. We think there'll be much higher uptake. So that is why the department is going more for the HPV as a primary test. So that more people can be reached with the screening, and to help us to meet the targets.
I think it's always that false economy. In the end, somebody needs to do the maths and realize that actually, even if the HPV testing is a bit more expensive, the hassles of the moment of people, a screening program that's not adequately reaching people will actually be offset in terms of cost on the long run. But that will come, we hope, eventually to make it simpler. Because I think the whole trick is how do we make it as easy as possible for the patients? Otherwise, they're not going to access the screening, no matter how fancy our services are. There's a question here about the presentation PowerPoint. Dr. Mandondo, are you happy for me to put it in I think it had actually downloaded in the end to my computer. Are you happy for me to put it in the Google folder for tomorrow?
Yes.
Okay, I'll do that. So
definitely, I'll send you a few things.
It's quite a large presentation because I think it's got lots of pictures, but I did manage to download it. Yes, it's 1 point. Yeah. So I will put it in the folder, in the Google folder of the maternal health resource pack.
Yeah, and maybe we can maybe cut it into half and remove some of the slides at the beginning. But
no, I can just, I'll shrink the slides. I know how to shrink the size. It's not a problem. I'll organize that.
All right. Thank you.
I don't see any other burning questions. Such a huge thank you. For me, this is such an important topic. And I think this saves lives. And I think it's partly also the more aware we are, the better we are talking to our patients and encouraging our patients. And those lovely posters, we'll be putting those in the Google chat, in the Google Drive folder as well. And I'm very passionate about getting them all translated into Xhosa. I already have somebody that's going to be able to help with the translation.
We've got the Xhosa version of the posters. We've got it. We've got Xhosa,
yes.
English. I must just check the Afrikaans, so I will give you all the.
Yes.
We'll give you the different, and we've also got another. Oh yes, there it is. So this is the one, and we've got another poster which is a hand, which then You can put in your consulting rooms, can print this in 8.5 and you tell you what is cancer, the science, this, and then we've got closer, and I think we've got Africans, so I just follow up and check on the Africans as well. So
yes, please.
and
I
these
think
were printed with help at the bottom. There's the National Department of Health logo, because they were endorsed by them, and it went through all the checks and the balances. So these are available for people. And I also think the register as well for booking a patient for call and the one for entering the results. I think these were also available to the department.
thank you very much. Yes, so you'll send me your bits. I think I might have some of it already, but just to make sure I've got the latest stuff, and then we'll add it, and we'll add it all to the list. There's a question here about organizing trainings. I was wondering about actually if one, I don't know how possible it would be through a webinar format. You probably might even have good YouTube videos in like, for example, LETS technique and colposcopy and doing a LETS because quite often you might even have the equipment, and with a very high staff turnover in some of our rural hospitals, it might be nice to have some training videos. And if not, if we perhaps organize a webinar late in the year where you do where we put together materials and we do a little online webinar video demonstration of colposcopies, LETS, VIAs, that kind of the actual technique of it. So that if you have because sometimes you have a facility where you've got one guy who does it and then everybody else leaves and then a bunch of new guys arrive, and it'll be nice to have training materials available in that for those new doctors.
So I think the actual technique, there's this presentation. If you go to the Knowledge Hub and you do sexual reproductive health, you can do everything on breast cancer, on this module, on cervical cancer. Then in terms of trainings, what we actually do, we use a sausage. We use a Vienna, not a Vienna, a cheese Russian, and then you can actually put it there, put it on something, and you try to do the LETS technique. So we will send. There's a link, like it says the large loop, the lip. It says the large loop removal of the transformation zone, and then on that video there's a link that has been done by Stellenbosch, and I think the practice we did a session where we did this over a day. And then we looked at this training package, and then we go to practice using the device, and we put it at the machine, and we use it on a cheese griller, and it worked very well for people to practice. Not to practice the technique and the skill, but we definitely need to do a training. We used to do this training whether 1.5 day, and be able to get this training so that more people are able to do the skill. But also after you've done the basic training, you can go to a tertiary or regional hospital close to you. And then you can once you know the technique, you've listened to the lecture and you've got the slides, then you can actually go to a facility where they have a LETS clinic. Maybe they do 5-10, and then you'll do that. And all the family medicine registrars go through that as well.
Thank you very much, Dr. Mandondo. I think that's a high note to end on. A very useful presentation, lots of tips, lots of, I think, inspiring also to get involved right on the district level. And yes, we'll put together all those resources, and I'll put all the links in the material pack for tomorrow. Everybody have a lovely evening, and we look forward to inviting you back next year, Doc.
Thank you very much. It is always a pleasure to be part of this. And thank you very much to all the people who sacrificed their time to attend.
Good night, everybody. Have a lovely evening. Next week, we will be looking at internal medicine, and Prof. Parrish is going to give us some top tips on various internal medicine scenarios in the outpatient department you might be seeing. So for something completely different. Have a lovely evening.
Sorry, Magdalene, to the team. We are currently launching the maternity care guidelines. And what we have, they will be launched and available to people. But at the moment,